Hi, everyone. Welcome to our webinar today on Next Generation Member Advisory Groups, a strategic tool to improve engagement, stars, and health equity. Looking forward to diving in shortly, but before we do, just a couple of housekeeping items. First, this webinar is being recorded, as you just heard. We'll be sending it out to you shortly after the session, along with the slides themselves. And then second, please feel free to put your questions in the chat throughout the session, but we'll also be doing a Q&A session at the end. Next slide, please. So now to dive in, I'm Casey Dugan, Director for Policy and Regulatory Affairs here at Faegre Drinker. Those of you who've joined us for these webinars before know that we've explored this topic on several other webinars. I think this is our 6th since 2022. And the primary focus of those previous webinars has been on new requirements for Medicare Advantage organizations that offer dual eligible special needs plans, or d-SNPs, to have enrollee advisory committees. But today we're broadening that focus to talk about taking advisory groups to the next level and using them in your STARS strategy, your health equity improvement and beneficiary engagement improvement efforts, and more. So I have some excellent speakers here with me today from Predict Health, Rex Wallace Consulting, and Hyperlift. So I'll go ahead and turn it over to them just to introduce themselves. Shub, would you like to start?
Great, thank you, Casey. Hi, everyone. I'm Shub. I'm with Predict Health. Quick introduction. Predict Health is a AI-driven analytical member intelligence solution. And what we do is we capture and collect member voice, understand what they say, and capture and collect member behaviors, understand what they do. And together, we use that to go deeper into understanding the barriers, challenges, and issues that members face and predict their action. We predict action to help payers and plans improve specific outcomes and their performance and operations, outcomes such as retention, STARS quality improvement, health equity improvement, as well as meet regulatory compliance needs. We work with a large number of plans across the country and many, many states. So very excited to be here, and thank you for joining. Turn it over to you, Rex.
Hey, thanks, Shub. Hey, everyone, Rex Wallace. I lead RWC, Rex Wallace Consulting. So we're a quality improvement consulting firm. We work with health plans across the country to improve all things quality. So heavy dose of star ratings there, as well as Medicaid marketplace and other lines of business. We do, we touch on all of the different programs that impact quality, including health equity, member engagement, provider engagement. So we've worked with Shub and Predict Health on some advisory councils with members that we've gotten tremendous insight from, and really excited to discuss this next generation of using these for even more power. Over to you, Mick.
Oh, I think you're muted, Mick.
Yep. I said, okay, thank you, Rex. My name is Mick Toomey, and I lead things at Hyperlift. And, I've got the opportunity to work with Rex and Shub on a very regular basis. We're an analytics, the STARS analytics, dashboarding, scorecarding company for the most part. It's probably how we're most known. But we work with a lot of plans, kind of regardless of size or performance level, and really help them understand what the numbers are telling them, how are we likely to end the year, projection-wise, and looking for opportunities to really optimize star ratings. So a lot of what we end up doing is kind of jumping in on stuff like this, understanding now that reward factor's going away, HEI is coming in, how does that change the way you think about stars? And very excited to be here today because, this is something that we've seen Shub and Rex have a lot of success with in the d-SNP population, and I think it just makes perfect sense to tailor this now to the HEI side of things. So thanks for having me.
Great. So now I'm just going to go through a little bit of the background and history of the use of member advisory committees or enrollee advisory committees or similar concepts in Medicare and Medicaid and public health plan coverage. So these are not a new concept. They've been around for a really long time. So for example, medical care advisory committees have been used in the Medicaid program since early in its history. I think they go back to at least the early 70s in terms of a requirement that state Medicaid programs have to meet. They're also used in PACE programs, in Medicare Medicaid plans under the Financial Alignment Initiative, and for Medicaid managed care plans that cover long-term services and supports, or MLTSS plans. And they've also been used kind of on an ad hoc voluntary basis by health plans of all different types, just when they're seeking to get more insights from their members on specific issues or at specific times. But in recent years, we've really seen them expand across different efforts and programs. And some of the most notable examples are on this slide, notably NCQA's Health Plan Accreditation for Health Equity, which was launched in 2021, has a member advisory committee component as part of its standards for meeting that accreditation. In 2023, as I mentioned, CMS required MA organizations that offer d-SNPs to create enrollee advisory committees, and this was kind of the first time that we've seen a requirement in Medicare Advantage. And then in 2025, new requirements governing the beneficiary advocacy committees that state Medicaid programs will use will take effect, and these requirements are far more specific and prescriptive than those that were imposed on the longstanding medical care advisory committees, especially as they relate to things like membership makeup, meeting frequency, structure, transparency, and reporting requirements, and the like. And so the expansion and growing use of member advisory groups really reflects the fact that the concept of meaningfully involving enrollee voices and input is a central component of health equity and representation when we're talking about health programs that serve low-income, elderly, disabled, and other vulnerable populations, and that these advisory groups are considered one of the primary means of achieving this. Another theme I'm going to talk about here is that CMS states and accreditation bodies are requiring or incentivizing more verifiable and repeatable processes for these groups. We see this especially with the NCQA Health Equity Accreditation and the enhanced requirements for state Medicaid programs. Just a lot more standardization and consistency across what they're looking for. And these factors mean that for many organizations, the committees have really had to go from sort of a box ticking exercise or something that is kind of done every once in a while on an ad hoc basis to really something that can or should become a central and consistent capability within the organization. And just to illustrate this, I'll call up the requirements for d-SNPs and just talk a little bit about what we've learned so far. And I know Chubb is going to weigh in here too. But again, this requirement took effect in 2023. CMS initially offered minimal guidance on how Medicare Advantage plans that offer d-SNPs were supposed to execute these. They did set some broad federal parameters, but left a lot of the details up to the MAO. And what we found in the first year is that setting these up in a way that promotes meaningful engagement and allows the MAO to get and use meaningful feedback is a really significant lift. And I know Shub's going to weigh in on that too. Oh, I think you're muted, Shub.
We are. Great, thank you. Thank you, Casey. So the issue that we see specifically around the significant lift to design, recruit, manage, and act on EACs is a challenge across all plans. The point Casey was making is it went from enrollee advisory committees or advisory groups as a whole, went from ad hoc, one-off basis to something more consistent, where the mandate or the requirement is moving beyond a single event, offhanded event, but really something more consistent in terms of experience, what you're putting in, the effort, as well as the expectations around it. And that is a significant lift because putting together an enrollee advisory committee or an advisory group requires a tremendous amount of resources and skills, different types of skills that need to come together at the same time to create an effective advisory group as meaningful for both the member as well as for the plan. It cuts across data analytics. It requires different types of data, marketing, communication, engagement, and then meeting management, but also interpreting the results. So what do insights mean, and how do you prioritize them? How do you compare events across different meetings as well as markets if you're looking at a national plan or a multi-state plan? And that can be really challenging. plans have started. They may be successful in some markets or some areas, given history, may struggle in other markets. And this is something that CMS has been identifying as they've looked across, and they've been conducting in the last year, at least earlier this year, reviews of the AC efforts across their 100+ d-SNP plans they identified. And consistently, what we found was that experience has varied, and the effort needed is significant. In fact, there are some estimates that per market, plans are required to, or expected, need to put in about 5,000+ hours to FTE hours just to meet the requirements, and that's a significant lift when you're cash strapped or resource strapped as a plan. But one consistent thing that we've seen across clients, across prospects, and all our conversations is the efforts that advisory groups have put up, the insights that they have generated, when done right, are of significant value. It provides a unique channel because it's an interactive mechanism to really capture member feedback at a local market level. And so really you're seeing this on the ground, and it fills and complements a lot of the gaps in knowledge that plans have. In fact, as we've worked with organizations, and this group, moving to the next page, we've this group on this call and the team, Rex and Mick and Faegre, we've been able to partner with health plans to realize significant impacts of this challenge, the value that plans have been able to capture, but just by doing applying a consistent process, and we'll talk more about that down the road. But really, if you design it well, you recruit, engage, and manage a series of representatives, advisory groups, and we've done this for plans of all sizes, all the way from large nationals covering many, many states to regional plans, to blues plans, to community plans, to plans of all flavors and all levels of sophistication. What we found is there's some learnings here, and our power has been that we've done now about 100+ advisory groups across 20+ states, and the value that we've been able to see is really when you have engaged members, and we've done this with thousands of members across multiple languages and different formats, and in person, virtual, as hybrid meetings located in multiple locations at the same time, gives you a level of insight and depth that allows you, the plan, with confidence to be able to take those insights back and implement change. The meetings that we've worked with and the clients that we've worked with collectively cover over 600,000 dual eligible members in this country, and this is really exciting to see when they work so well and can be a powerful tool. And this is not just a one and done. With these meetings, when you do it frequently, you're building trust, you're building a communication channel, and an ability to capture unique insights back for the plan, and that can be really valuable. Turn it over to you, Mick.
Yeah, I'll echo everything that Shub just said. I had a number of mutual clients with Rex and Shub when they were rolling these things out, and so I got to see firsthand the power of these sessions, the insights, the benefits that can be garnered by putting these together, executing them well, and based on that success, we were talking about the biggest challenge that's coming out right now, challenge and opportunity around Medicare Advantage stars. And if you take away the potential impact of the proposed QI, hold harmless change, this is probably the biggest thing we've ever seen, and that's taking the health equity index and replacing it with taking the reward factor and replacing it with the health equity index. And you start looking at the impacts that can have both on plans that are used to the reward factor or those that have never gotten the reward factor. This is a really fundamental shift that we all believe that these advisory groups can really help to begin to dig into what's driving some of that disparity, and how to address it. We can go to the next one. And so, why do we say this is both the biggest challenge and opportunity facing kind of Medicare stars right now? If you think about the reward factor going away, this is a fundamental shift in overall stars math. And when you look at especially these high performing plans, they're used to getting 20, 30, 40 points of reward factor every year. And it's become the expected thing. And so being able to, one of the challenges they're facing is, making sure that leadership understands what's coming, what kind of an impact is it going to have, what do we do right now to be able to get ahead of these things. And I think that there's a bit of a misnomer when they say reward factor is being replaced by the health equity index. One, the average reward factor bonus is about 28 points, whereas CMS estimates the average HEI to be 11. So you're not just going to be able to take one and replace it with the other. And kind of in line with that, the plans that were getting these high reward factor bonuses based on their population is these are likely not going to be the plans that are really getting high bonuses on HEI. And just to kind of explain, put in actual terms, why this is so challenging for these higher performing plans, every 4.5 and 5-star plan earned a reward factor bonus in stars 2024. So every one of them used, some kind of additional points added to be able to get up to the star ratings that they were. And over 90% of the 5-star plans received a reward factor of 40 points. So you think about the kind of impact that can have. That's easily a half-star change. And none of them received a bonus less than 30 points. And then when you take all of that and kind of aggregate it in, if you took away the reward factor, just for modeling's sake, in stars 2024, none of the 5-star plans would have stayed 5 stars. And I think that that's a really powerful fact to kind of digest, internalize. Essentially, taking away the reward factor kind of killed the whole 5-star category. And that has a number of different implications as you start applying this, especially when you're looking at the QI hold harmless changing potentially to 5 stars instead of 4. It's just changing the game for, at worst, all of the high performing plans. And the final point that I'll make on this one is when Tukey came in, you saw downward pressure on the overall star scores. And what that ultimately meant was you're seeing a decrease in the threshold to hit 4 stars, or I'm sorry, to hit reward factor. So for the first time in many years, the reward factor ended up being this catapult to actually push people into 4 stars instead of just being kind of known as a 5-star maker. So in this situation, last year at Stars 2024, there were 12 contracts that wouldn't have been 4 stars without reward factor. And when you look at the QBP payments that came along with that, it's about $400 million. So that going away really has a tremendous impact on anybody kind of 4 and above. And so when you think about kind of what does this ultimately do to that group of plans, any of the plans that are being proactive and thoughtful about, these changes are coming down the pipe. What do I need to be doing to get ready for this stuff? They're finding themselves under a whole lot of pressure right now to be able to recoup, some of that 20, 30, 40 points that are just absolutely going to go away with the reward factor. So that's kind of the overall in terms of why this is such a big challenge for, a good percentage of the overall contracts out there. We can go to the next one. And while it's going to be kind of devastating for some contracts, it's kind of a non-issue for others, or it's a real opportunity for others. But when you look at it more broadly, there are opportunities that exist here with this change. If you think about your situation and you figure out how to best approach it to take advantage of some of these things, whether a contract is going to be eligible or not for HEI, it's still, there are still things that you can take advantage of if you focus on improving access to care and overall performance of the SRF population. There are a lot of things that can be gained from just a straight stars math perspective. One thing to consider, you think about kind of the timing of HEI coming in. We are being measured on it right now, but the scores aren't going to come in until stars 2027. But with the member experience weight change, so for any of you who don't know, a lot of the member experience weight changes or measures went from a 4-weight to a 2-weight this year for stars 2026. And really what that means is everything else, all the other measures, actually increased in relative weight. And so, making changes on those other measures actually has more of an impact than it did, say, last year. And one of the biggest ones are those 2 5-weight QI measures, Part C and Part D QI measures. I won't go into a ton of detail on this, but because they stayed at 5-weight and the overall weight of stars went from 100 to like 65, they have now a really significant impact on your overall star scores. And so being able to play into that, we can hit that next little bullet here. This plays into this quite a bit. So even if you're not getting HEI, there are ways to benefit here. And I would say this first bullet, whether you're, you look at reward factor, it's always been high performing plans, right? For the most part, 4-star and higher. But now a lot of the plans that were never going to be eligible for a reward factor bonus, because, as we all know, we've seen with this disparity, it's much more challenging to operate a membership with a really significant SRF population. So now these plans that really never focused on reward factor now have an opportunity, if they're showing really strong performance with their SRF population, to get, again, up to a potential of 40 points added to their score. So kind of evens the playing field to a degree, or at least provides opportunities for plans where this wasn't an option before. And another thing to think about when we're looking at the opportunity side of things, if you've just traditionally been a lower performing plan, kind of regardless of the percentage of SRF population that you have, there are a lot of opportunities. I think what we're going to see is a whole lot of focus in this industry about how do we improve access to care, overall performance for the SRF population, kind of across the board, at least for the plans that are really trying to figure out how do they optimize their scores. And as a result, there are going to be new opportunities to improve your scores. So even if you're not going to get some of that HEI bonus, you can still reap the benefits of like improved QI measures. If you're able to improve the performance of that SRF population, that is going to improve your scores, which in some cases could lead to higher star ratings. But in, I would say, more cases, it will lead to higher QI measure ratings. And you'll see on this next bullet, but for every one of those that you increase the star rating for one of the 2 QI measures, your score will go up almost 7 points. So it's a real opportunity to start taking advantage of that, because the move to get to that QI is much smaller often than to get to the next star rating. And finally, with the high performing plans, same kind of thing. They may or may not be eligible for HEI, but if you're a high performing plan, you know how to offer care. It's a very different world offering care to the SRF population. So it is something they're going to have to adapt to and learn. But if you can exercise some real improvements there, it can drive a lot of improvement. And I would say for those high performing plans, biggest opportunity is take advantage of that to drive QI rating improvement. And so kind of overall, no matter what your SRF population might be, really owning and internalizing and putting focus on how do we improve the SRF population, it should lead to some pretty significant star rating gains across the board. And you'll have to look, each contract's going to be different, but you can look at that and understand where your opportunities might be. And I would say, obviously, if you're one of those plans that does have a significant SRF population, being able to take advantage of that HEI reward and get up to potentially 40 points is a real opportunity. So this is why I wanted to jump in with these guys and do this, because I think this is a really unique opportunity to provide a valuable, proven way to go after this population, where traditionally, plans have really struggled with this. So I see this as a real opportunity kind of across the board. And one thing to kind of wrap this section, I think it's valuable to at least talk in theory, kind of like how we are looking at where you'd want to focus if you're going after like specifically the HEI reward. If you're trying to optimize that score, I think one approach could naturally be, we got this list from CMS, and here are all the measures that are performance. Let's go target all the ones that we're really low performing on. I think that, logically that could make sense, but because of the way this program is structured, we don't think that's the best way to go about it. Really, I think what you want to look at is where we're calling them bubble measures. So the report that you guys got in HPMS, it is HPMS, right, Rex? Yeah. So there's a report CMS sent out that showed you kind of where each of your measures are relative to these thresholds. So essentially CMS went in and said, you have 3 thresholds, kind of the lower, the middle, and the upper. If your SRF measure performance is in the upper, then you get 1 point times the weight, for that measure. If you're in the middle, you get 0. And if you're in the bottom, you get -1. So really the way to think about this is what you want to do is get as many of your measures out of the bottom into the middle, or out of the middle into the top, and then protect the ones that are in the top to make sure they don't drop, or in the middle, make sure they don't drop. And so the way we look at this is bubble measures. So you can see here kind of opportunity zone and risk zone. Instead of just focusing on the bottom performers, you want to look at the ones that you kind of have a shot to either protect the threshold that you're in, or bump up the performance and take a shot at getting up to that next threshold. So we kind of look at a tight band and try to figure out on a contract by contract basis which measures make sense to go after, because we can't boil the ocean. So this makes it much more approachable, digestible, to understand which measures do we need to go after, how do we figure out what are those barriers, and begin to move the needle. And so again, a lot of it is just kind of getting into the root cause analysis, but it's for a much smaller number of measures. So you're much more likely to actually be successful in achieving these objectives. Anybody want to add anything to that? I mean, I think it's kind of that first step here.
Not yet.
Focus on, Rex, so the one point I wanted to make was thinking about measures on the bubble is really helpful, because it narrows down or takes a problem which seems unwieldy, because plans have struggled with improving performance for SRF populations across the board, and it's and if you can narrow down that problem to something, which ones should be prioritized, and what do we need to do? It's much more tangible, much more in-year and actionable in a near term. Once you're able to prioritize which measures you should focus on across all of them, you should.
Ideally, you're focusing on all of them, right? Yeah. But I think the interesting point is whether you're moving something from the bottom to the middle or the middle to the top, it has the same impact on your overall score. And so, just from an optimization standpoint, it makes sense to focus on the measures that you have to move the smallest amounts, you know,
Right.
to be able to get those gains, or just bump up the ones to make sure they don't drop. So again, just gives you a kind of a tighter mix of measures to actually go after.
It's much more strategic.
Right.
And the other piece was when you have a much narrower focus around measures, root causing the challenges out can be much more workable. Figuring out exactly what the challenges are and which population is affected by which measure and where they are in which market allows you to then say, okay, this is where we swarm with our resources in this time frame, allowing us to then move the needle on the measure itself.
Yeah, it's a great way of describing it. And you know, I would also just say, for everybody's sake, you know, to a degree, the HEI calculations are still kind of black box. You know, CMS hasn't released everything yet. And, you know, at least, you know, what we're talking to our plans about is, you know, let's not get mired in what we don't have right now. Because at this point, again, just coming at it from a straight kind of bubble measure standpoint, the details will come and we'll work all that stuff out. But if we go after this, you know, it's that whole, we don't want to be paralyzed by the lack of information. There's still plenty of information that we do have to enable us to chart a course and begin to drive that improvement.
Rex?
Okay, sorry. It was saying my internet connection is unstable again. So you can hear me okay?
That makes sense.
Sorry. Did you ask a question or just is it ready for the next slide?
Yeah, I was turning it over to you.
Yeah, no, and you know, I think after hopefully after the next couple of slides, you'll understand why we really felt the need to go deep here. And you know, you just heard from Mick, right? So Mick and I both, you know, eat, breathe, and sleep star ratings, right? And this is which, you know, in our opinion, Rich is biased, is, you know, the most important aspect for a Medicare Advantage plan to be competitive, right? It drives so much revenue. So you know, again, been working with Shub on these advisory groups, and just to kind of recap what we've heard so far, right? So like Casey said, these advisory groups were mandated, so we had to stand them up for d-SNPs, which we did, and we found to be incredibly valuable for not just for the mandated reasons, but for feedback in general to, and I guess the mandate is really for d-SNPs to include the voice of the member in plan governance, right? And that's the whole concept here, is to capture the voice of the member. So, which I would argue we as, you know, health plans have a lot of room to improve, right? In capturing that feedback. And this has proven to be a very important and very effective vehicle to do that. So as we thought about, like we've said, right, these things went well. We learned a ton. We really engaged with members. And as we started digging into the Health Equity Index, which, like Mick has said, is the biggest change in star ratings right now. And if you're not a Medicare Advantage plan, just understand that we're only using Health Equity Index as a case study here, right? This is just one example of a non-mandated thing that you can use these advisory groups to really understand and improve your performance on. So don't, you know, if we're getting pretty in the weeds with Health Equity Index, don't check out, just understand this is a case study. There is to paint the picture of all that we can do with these advisory groups that we're not doing yet. You know, that being said, if now that you've had sort of this crash course on Health Equity Index, what do you do, right? And knowing that we have these advisory groups stood up in a lot of organizations now, or there is the opportunity to do so, what do you do? The first thing, as in anything, right? Understand your own situation, you know, N equals 1 here for sure. So this Health Equity Index is a component of the STARS program that affects everyone, but it affects everyone differently. Depends on your population. And that's the first thing you have to do, is really understand, you know, what is your population. So, you know, Mick described these social risk factors, right? So let's imagine that you are this pie chart on the left, right? So the first thing you need to do is understand who are your members with these social risk factors as defined by CMS for this health equity index. And those are the Venn diagram on the right? So, and these are three, as it says, distinct segments that you need to understand. They're not all the same. We're all guilty of, I think, treating Medicare Advantage members as all the same when they are very different. But by age, by disability, by chronic condition, by age, ethnicity, et cetera. Same thing here. These are all social risk factor members, but it's three very distinctly different segments. So the first one, the top biggest circle there, are dual eligible members. These are members who, have Medicare and Medicaid both. So these are members who because they have Medicare, they're either elderly and or disabled, right? So that's that population. They tend to have a lot of chronic conditions. They tend to be, these will be low income because they are Medicaid too. And then the circle to the right, the low income subsidy. These are Medicare only members who are low income. They're not on Medicaid, but there is a low income subsidy here. A little different than a Medicare Medicaid member. And then on the bottom left there, the portion who are disabled. And to be completely accurate, these are the members whose original reason for entitlement in Medicare was disability. So it's not all of your disabled members. It's not people who joined Medicare Advantage and then became disabled at some point later. These are the members who were under 65. They were not eligible age-wise for Medicare, but they had a disability that made them eligible to join a Medicare Advantage plan. It's that bucket. So these are three very different buckets with different access to care challenges, different socioeconomic makeups, different abilities to engage with them, different ways to, I would say, I would say they all three are underserved. They all three have lost trust in the system and in the industry, right? And I would argue that most Medicare Advantage plans probably have a low understanding of who are in these buckets and what makes up the members in these buckets. So that's the first thing, is to really understand that. And that's the whole point of these advisory groups, right? And go to the next slide, please. Right. So the opportunity that's before us here is to leverage all that success that we talked about with the advisory groups. And I can tell you, I'm in over the last 18 months, I've been in a lot of these advisory groups, and it's arguably my favorite meetings, right? Every month, sitting in a room, either physically or a virtual room, or a hybrid room where we have 3 locations in the state and we're connected by screen, but there's some members at home, some members in rooms in 3 different cities. They are very well put together, and sitting in there and and hearing directly from the members, there was not just their responses to our question, which you can get from a survey, right? But actually being able to sit across the table or across the screen and drill down and to get an understanding of why exactly they answered it like that. It's incredibly valuable. So we want to leverage that concept, right? That structure to better understand what are the barriers to care for our health equity index social risk factor members. And this is a great channel to do that. So down at the bottom, we actually start this is painting the picture of how do we actually do this, right? So we have the health equity index and social risk factor member. So the first thing is to identify the bubble measures for your organization, to dig in, and like Mick just laid out on that prior slide, right? On one of the prior slides, to understand which measures are going to require the least effort for you to move up or to keep from moving down. So the ones that are on the bubble, you don't have to focus on all measures. And this is definitely a secret, I would say a secret to success for stars, right? Is being surgical, not boiling the ocean. I mean, all those different analogies, but to actually identify the least number of places where you can focus on a measure and either move it up because it's reachable or to keep it from moving down. That's a secret to success for high performing plans for sure. So the first thing is to identify those bubble measures in your health equity index, digging in to your own performance, right? Your own data, either internally or with help, someone like, us and Mick or whoever, but to really understand your current situation. And then next, step 2 is to create not just one advisory group for health equity, but we really believe, because these 3 segments are so distinctly different, to have a different advisory group for each one. So you'll have an advisory group for disabled members, where you will dig into to those specific challenges, and the responses and feedback that you get from that disabled population won't be tainted or watered down or diluted by feedback that you're getting from other segments. So you are having a comprehensive conversation with a group of disabled members, recurring over 3 or 4 times a year, to gather that feedback, and so then you can act on it. But same thing with low-income subsidy members, same thing with dual eligible members. Each one very unique population, very unique needs, and worthy of their own feedback mechanism, right? Where they actually can participate. And I'll pause for a second because I want to say one thing about these groups that I've sat in is, because if you think about members with social risk factors, right? It's called health equity index for a reason. These members are not equitably cared for. They don't have equitable access like everyone else. That's why we're focusing on them, right? They have, like I mentioned, most likely they have low trust in the system, and they've felt disrespected by the system. In my experience over the last 18 months, sitting in a room face to face, these members are in there with decision makers from the health plan, right? This is not a customer service call. This is I'm in the room with decision makers. They're asking me questions, and it is a way to build trust with these members who have lost trust in the system. So for them to share feedback, for them to have their feedback heard, and to know that it's probably being acted on, and that's a whole nother step that we'll get to in a second. But it's a way to build respect by listening to them and meeting accessibility standards. So, a lot of their access to care challenges are around transportation insecurities, right? Or financial insecurities. And these meetings are designed to overcome those insecurities, right? To provide transportation for these members, or to provide a device for the members so they can check in, they can conduct the meeting from home, where they don't have to travel across the state or get into a van if they don't want to, right? Predict Health has done a great job working with our clients on designing this and making it accessible. When you make it accessible, when you meet these members' accessibility challenges, you build trust, right? You're showing them that you respect them, and that you are meeting them where they are. And that's an overused term, but really meaningful here. Okay, and step 3, right, is to understand the social risk factor ratings for every measure. And here, right, we want to, what are the most important measures for each of the social risk factor groups? So again, don't want to boil the ocean. We get into these sessions for, let's say it's an hour and a half with 15 members or something like that, right? We want to have a meaningful conversation. We want to not have 25 different measures to touch on. We'll never get through that. What are the most important bubble measures from this health equity index standpoint for each of those 3 distinct groups, and make that your agenda, right? Make that your topic, where you dig into the most important measures for that disability population, or that dual eligible population, or that low income population, so that you can really understand the challenges. And the step 4, right, is to uncover those barriers. So to have those conversations, right, to conduct the advisory group, and to dig in and uncover the barriers for each of those bubble measures for each social risk factor group. And then step 5 is money, right? And this is where it doesn't matter how good your strategy was, it doesn't matter how well designed your advisory group was. it doesn't matter how much funding you have or how your CEO says, hey, this is a top priority. If you get this feedback and don't act on it, you fail in so many areas. Number one, you're not going to improve, but number two, all the trust that you've tried to build with these members and these committees and in these advisory groups will be lost if you don't do anything with it. They will know. They will ask you in the next meeting, what did you do with the feedback that we gave you? And if you can point to changes that you made, you will win these members over and all of their friends and family, because they will feel trusted. They will not just feel, they will trust your plan like they didn't before. If they can be in the room having conversations with decision makers, and then actually know that their feedback was acted on and improvements were made, on the feedback they provided. I'll stop there. Shub, make anything?
Yeah, just jumping in. So going back to the previous page, please. Just knowing where to focus. So we get our measures. In fact, in the next 2 weeks, we'll have an early preview of our stars for the year, and you'll get a sense of where you're going to land or expected to land going forward. So what that means is, okay, you know where your problems are. Just knowing your problem can be helpful in terms of heat seeking, but then how do you solve the problem is where some of the biggest challenges lie. So how do you solve the problem? What does it mean? Why are your members rating in a certain way, or why are they acting a certain way? What are the root causes of those barriers, the challenges they face? That's what the interactive nature and this open conversation nature of advisory groups allows you to unlock. And really, from this process that we've identified is, in one, you're able to understand the measures to focus on, zero in on things that matter to you and your plan and your market, and then understanding how that plays out, really understanding what are the root causes of the issue for that population, because each of the groups that make up the population with social risk factors will vary by contract, will vary by market, will vary considerably. You may have a larger disabled population, some areas versus the LIS population in others. How does or which is typically the case, large dual eligible population. How do you ensure that you're listening to the equivalent voices to make the changes, be it through benefits design or vendor selection or program design itself, to enable and unlock the value for some of the key barriers that members face here. Going to the root causes is absolutely critical, because by understanding the root causes for each of the individual groups, and here we have CMS has identified these 3 subsegments. There will be others in the future. Understanding the root causes, how these measures play out in each of these groups, and then putting it all together and said, based on your population, your representativeness, how can you take this feedback and create this punch list or the prioritized list back for the organization that you can allocate resources and time against, which comes together at 5. Rex's organization and team can help put those together and help you really rationalize, okay, where should we focus on, and what's the bigger bang for the buck in terms of impact for moving it from a middle order to the top, or from the bottom to the middle, or preserving and protecting your stars as is. Putting that strategy allows you to build an improved performance on your SR population with the lowest set of resources and most efficiently and effectively. Is there anything more to add, Mick?
I think you guys hit a lot of the key points. I mean, the whole idea is figuring out how to tighten all of this up and then understand what's driving any of these disparities and how we might, go about addressing it in a very, again, digestible manner. Let me throw this out. There were some really good questions that popped up. I just saw that in the comments. Stub, do we want to address any of those questions right now, or do you want to push through and address them at the end?
Why don't we push through 3 more slides, and then we'll be able to pull back up and talk through the questions.
Okay.
Shall we?
Great.
So let me move to the next piece. So a key driver of really unlocking the value and moving measures, be it HEI measures, be it STARS measures, is knowing where to focus and knowing which population is impacted by it. So really then you want to understand what does that population say? What are the challenges and barriers they face? And what is the feedback that they get? So this is where advisory groups, and this is what we're calling the next generation advisory groups, are able to do that. So it's really reflective of your population that you want to understand, to be able to create, using data, tools, and technology, really create representative groups that you can study in a much more effective way and learn from in a much more effective and cost-effective way. And so what we've done with our experience across the years as a group, where we worked with launched and managed over 100+ advisory groups in multiple states, multiple languages, thousands and thousands of members, attending meetings as well, managing them in panels, gives us a set of insights that are scalable and applicable here, that are really relevant for unlocking and improving and understanding that last mile that you need to really improve your STARS ratings and HEI measures. So how do you use advisory groups to better understand the challenges and issues for that specific population is really key. And what we've applied and built here, which is easily transferable to plans of all sizes and all levels of sophistication, is a consistent and effective approach and methodology that is flexible to meet your resources and your needs and your population's needs. It's data-driven. It's data that we know plans have, but they don't have all the data about their population. We, as a Predict Health, has built this massive understanding of members, and we have a lot more detail around member demographics, their situation, where they live, the technology savviness, and so on and so forth. So understanding that, bringing that data to bear, and the analytics allows us to then build representative groups. So this addresses a common challenge that plans have had with historic advisory groups, is that they don't tend to be very representative. The second is it could be timely. How you recruit, how you engage, how you manage will allow you to be much more timely and relevant with your meetings. It is across all your data collection efforts across your members, an advisory group is probably the fastest way to collect your data. Surveys take a while. You're limited by CMS or when you can do your surveys and data collection. Advisory group can turn it on within weeks, and you'll get data in the market, on the ground, deep, very quickly. How you manage and engage your members, if you use predictive analytics, which we do, to engage them with precision engagement, you'd be able to easier to recruit and manage them and engage them. And then, given the use of technology and tools, it's much more scalable and cost-effective to run. This, when applied to STARS, taking these learnings and this experience from the enrollee advisory committees and other advisory groups and applying it to STARS and HEI, gives you a set of tools and power for the first time that allows you then start going that really understanding how do you take a measure and make it real and unpack it to really improve value. And the three pieces that I'd like to highlight very quickly on the last page is the areas where we focus, and this is learnings for everybody. If you're trying to build advisory groups for tackling these measures and building an experience for your members and a channel to collect their feedback, the most important thing, and one of the very important things, is really make sure that they are targeted and representative. So you're able to capture and collect, put together advisory groups of members that are representative of the population you want to learn from. And this is absolutely essential. You don't have as much detail as you need typically to really understand first, who's the population you want to study. So if you're looking at SRF groups, if it's a dual eligible or disabled population or even the LIS population, what does that group look like in your entire market? You really want to understand what that group looks like, and not just age and gender and location or geography which people have, but really on the softer dimensions, access. What's the technology savviness? How do they engage? Really be able to understand, create a full picture of that population. So that's imperative. You really need to understand that. And when you're missing data, we are able to supply that and provide you that full picture. Once you have that full picture, then you need to really be able to select that subgroup. Who should be a representative group, because you're trying to boil down from thousands to a dozen members. How do you make sure that the members you invite are representative of the larger group? We have tools and technology we've built, a representative scorecard to really help you do that, and that allows you to then make sure and gives you the confidence to say the group in the room really represents the membership that I'm looking to study, and that gives you the ability to act on the feedback you get. Once you have that, how do you engage that the members, and how do you make sure that you build that pool together and maintain that pool? The key here is panel management. Anybody who's doing market research will tell you it's impossibly hard and it's extremely expensive to recruit meeting by meeting, event by event. What you really want to do is build an appropriate panel and engage them in a smart, effective way, and keep that. That's your keep warm group. That's your bench, if you will. And how do you draw from that group from time to time when you have the meeting? So we spend a lot of time really understanding and thinking about how do you manage a panel, and how do you make sure that the panel is representative and there are enough backups in your panel should anybody drop out of a meeting, and so on and so forth. And finally, technology. There's data and technology that we bring to make this process a lot more efficient, manage it not just for a per meeting basis or event basis, advisory group basis, but really across meetings, across markets, and across time. Because this is an engagement driver of your and a learning tool for your organization. And it has CMS has requirements around compliance and so on and so forth. But really, it is instead of repeating this process, there are thousands of hours of FTE hours that are spent per meeting. If you do it yourself, how do you do that efficiently? And we've built technology and software that we're releasing across the next few months to help you manage that. And this is designed to be either run by our team, working with you, or our partners, or even with your team running it independently. And that takes me to the last slide, which is really our approach is really flexible, where we can work with you and with advisory groups, working with Rex RWC and Hyperlift in an a la carte basis. So you just need a little bit of help on identifying the bubble measures, or identifying what that means, or creating a focus group, or even recruiting, for example. And then all the way on the other side of the spectrum is where we can run the whole thing for you, working closely with identifying the measure, running the meetings itself, specifically around measure focused or market focused or population focused, or some blend along the way. With that, let me actually turn it, let's go back to the questions, because there were quite a few good questions that come up. So the first question I saw was around the number of hours. I think Tisha had a question around, was it 5,500 hours FTEs? It was 5,500 FTE hours per meeting per market, so just to clarify. So that was the first question.
Great. And then oh, sorry, I don't know, Mick, do you want to take the one on using the data from the HEI points?
Yeah, I think there's another one that's kind of related to that.
Okay.
So in that document from HPMS, it does have, your score and where you fell relative to the national averages, if you will, and in those two different thresholds. So they're different cut points than you would see like for a normal STARS calculation. And like one of the challenges with the HEI right now is you have these thresholds that CMS pushed out. Data's a little bit old, but kind of like when a new measure comes out, you expect to see more movement, more improvement than average for these measures, because now that CMS is actually measuring it, they're rating you on it, people are going to focus on that more. So you see performance tick up. We don't have a lot of history, like we forecast cut points every year because we have this history to kind of fall back on. We don't have that with HEI. So it's something we're building from the front. So I think if you use the thresholds that CMS published, it's a good starting point to come up with your bubble measures. And I would just think at some level, those thresholds, you've got to expect them to go up a certain degree. To what degree, I'm not sure yet. But they will go up, so that plays into how you start thinking about the bubble measures. and how to identify those. And then if you're having any trouble with the HPMS stuff, you can message any of us. We've got models. Like when they changed the way, they took away reward factor, did all this, we create models, and we don't charge for them, and we're not going to hound you for sales and stuff like that. So if you need help, just reach out, and we're happy to share some models with you. And actually, Rex and I did a pre-conference workshop at Qualapalooza early in the summer, and we have a lot of slides on how HEI actually works, how it's calculated kind of at a relatively nuanced level. So if you have any interest on kind of getting HEI 101, also just let us know. We'd be happy to shoot those over. But does that answer the question about the scores and the cut points?
Yeah, I think. Oh, sorry. Go ahead.
Okay.
No, go ahead.
Well, I was just going to say on that other one, on the 1241 anonymous attendee, what threshold should be used for each of the three groups is necessary before an advisory group of each should be developed. I would just recommend use those thresholds that CMS pushed out kind of as a general starting point, and then that will help you understand which measures you might want to include in those advisory group sessions.
Right. I did answer that question online as well. It was another way to interpret the question was, what's the minimum number of members do you need in each of the subgroups to have an advisory group? So we've seen value. We work at plans of every size. In some markets, they may have a few hundred or 100+ members. In some, you may have tens of thousands. In the smaller markets, surveys are ineffective because there's very few responses, and those aren't really reliable. So advisory groups even at the 75 to 100 level market or population will give you a tremendous amount of insight. We've distinct approaches for small markets as well. And if you have I know in some markets some clients we've populations for disabled population to be much smaller. Their ongoing feedback versus one event can be a variation, but highly valuable in terms of capturing insights on an ongoing basis.
Great. Well, this has been great. Thank you all for the great questions and for joining. I know we're a couple minutes over, but if anyone has follow-up questions or would like to connect further, just a reminder that all four of us have our contact information in the slides, both email and phone. I'm sure any of us or all of us would be happy to answer further questions or connect. As a reminder, we will be sending the slides along with the recording out shortly, so look out for that. And otherwise, we look forward to meeting again on this issue, and we'll send out that invitation as well. So thank you again, and don't hesitate to reach out.
Thank you all.
Thank you.
Yeah, thanks everybody.
Okay. Thank you.